another young surgeon, Dr GITANSHA Sachdev, and she works at the Eye Foundation, and she'll be talking about Femtolaser. I think more and more people, there has been a growth in the number of procedures of Femtolaser between last year and this year of more than 100%. That's the growth that you have of the number of procedures that are being done. So she's going to talk. Sure. She's going to talk about Femtolaser assisted cataract surgery in complex cases. The normal cases of cataract surgery can obviously be dealt with the Femtolaser, and often people feel that there isn't much of a difference, but it is when you are dealing with complex cases that the real power of the Femto comes into play. So over to you, Dr. GITANSHA.
Thank you. A very good afternoon to all of you. So my talk would be on femto-assisted cataract surgery in challenging cases. I have no financial disclosure. Now we're all aware that femtosecond has brought about an unparalleled accuracy and precision over the conventional phacoemulsification. But do all these advantages, such as a precise capsulotomy, a lens fragmentation, hold good in complex cases? Well, the answer is a resounding yes. So over the subsequent slides, I'll be showing you certain complex cases wherein we used the femtosecond laser. The white cataract, as we all know, is a challenging case. One of the major challenges in the white cataract is to initiate and get a proper capsulorhexis. The increased intralenticular pressure along with a poor red reflex very often increases the risk of a runoff, or what we call the Argentinian flag sign. Additionally, there are times that there might be an associated fibrosis or a zonulopathy. So how the femto helps here is that the most challenging step, which is the capsulotomy, can be done with relative ease. This is also important in premium IOLs, where it's very important to have an accurate ELP. The femtosecond here works in a closed system, so it delivers a precise capsulotomy every time. The important thing, however, is to always stain the capsule with blue, because sometimes that sudden egress of fluid from within the lens can obscure the underlying structures from the femtosecond delivery and result in certain uncut areas or tags. These can easily be dealt with by either using a cystotome or a rhexis forceps. The femtosecond, however, does not penetrate very well in these waterlogged intumescent cataracts, and the nucleotomy may be slightly suboptimal. When we're moving on to the hard cataracts, we know that this is a challenge because of the increased risk of a posterior capsular dehiscence and also because of increased risk of corneal endothelial damage. So the femtosecond cataract helps in both of these conditions. Various studies have shown that the effective phaco time is drastically reduced when we use the femtosecond nucleotomy over traditional phacoemulsification, and this advantage is even better when the grids that are used are a smaller size. Again, the advantage is better with higher grades of cataract. So this is a LensX system wherein you can see a matrix pattern which essentially breaks down the nucleus into very, very small cubes by multiple vertical cuts with two interspersed horizontal spiral in patterns. So what you're left behind with is a very easy nucleotomy which requires much less phaco energy, and what you get are clearer corneas and reduced postoperative inflammation and obviously a happier patient on day one. So this is an example of a rock hard cataract. It's about grade 4 to 5. This is just to show you that the femtosecond laser actually penetrates throughout the entire depth, and it gives you grooves which are sufficient enough to make the cleavage very easy subsequently. The bubbles that you saw which were released were as a result of the Nemo dissection that the femtosecond laser induces. The next one is posterior polar cataract. Dr. Tityal has already very eloquently and comprehensively covered the entire use, but I'll just touch over. One of the more important things that this helps in is that it avoids the need for a hydrodelineation, because the femto lasers, in a sense, produce a slight amount of a pneumodelineation. Another important thing that Sir had pointed out was that in these cases we can leave behind a thick epinuclear sheet. So how that helps is it's kind of like a cushion to the posterior capsule from all the hydraulic forces that take place while we're doing the nucleotomy and removing the central core. The AIOCT is also a very useful tool which allows you to see before you enter. And the posterior capsule can actually be imaged to get an idea of whether it's intact or if there's any dehiscence before the surgeon actually enters the eye. So we had published this. It's a result of 50 eyes who had undergone flax with PPC, and we saw that there was a 100% negative predictive value, which means that in the eyes in which the posterior capsule was intact in the AIOCT, none of them had an intraoperative posterior capsular dehiscence. So this is just a short video. You can see that this is a posterior polar cataract which has already a pre-existing posterior capsular dehiscence which can be seen on the slit lamp. So we're using the catalyst system in this to dock the eye. So this is what I was alluding to earlier, wherein the AIOCT actually gives you an image of the posterior capsule. And here you can notice that there's an area of defect or dehiscence in the posterior capsule which kind of warns the surgeon beforehand that there is an increased risk for the capsule to give way. So very important step here is to increase the posterior offset of the nucleotomy to get a thicker epinuclear cushion or sheet which will protect this posterior capsule while the nucleotomy is happening and while the central core fragments have been removed. The vitrectomized eye is another challenging case. The silicone oil in the posterior chamber does obviously change the red reflex, and also it increases the pressure wherein it's harder to get the capsular rhexis. There might be additional epithelial, corneal endothelial compromise or a posterior capsular touch or a zonular weakness. So the femtosecond laser, again, like in the PPC, helps you to see the posterior capsule. Again, the posterior offset of the nucleotomy should be raised to give a cushion. You can see that in this we're doing a capsulotomy and the nucleus has been fragmented into 4 quadrants. Again, this nucleotomy will drastically reduce the amount of phaco energy that one is using, which will give better results vis-a-vis the corneal endothelial damage. So you can see the red reflex of the silicone oil once the cataract has been removed, which is followed by an intraocular lens implantation in a well-centered capsulotomy. A word of caution, however, in these is to look for emulsified silicone oil in the anterior chamber, because there are certain cases wherein this emulsified silicone oil might be present. This will interfere with the subsequent delivery of the femtosecond and result in uncut areas underneath, as you can see here in terms of the capsulotomy as well as the nucleotomy. So in these cases, perhaps it might be better to avoid a femtosecond laser and proceed with a conventional phacoemulsification. Glaucoma or high intraocular pressures was considered a relative contraindication for the femtosecond laser because there was an increase in the intraocular pressure during the dock. However, with the advent of the soft fit PI and the liquid interface, this is no longer a contraindication as the intraocular pressure rise is now much lower. The only important caveat that one needs to remember here is that the suction ring has to slightly be decentered to make sure that the area of the bleb falls within the ring so there is no suction loss, and also there should be no damage to the conjunctival tissue. You can also appreciate the bleb that was there on the AIOCT imaging. So this was just followed by, the rest of the steps are normal with the normal capsulotomy and the nucleotomy that the surgeon prefers based on the grade of the cataract, following which the remaining procedure can easily be done. Another contraindication was a small pupil because this essentially limits the capsulotomy that one can do and the nucleotomy within. But now it is also possible to insert these pupil expansion devices, like you can see that the Maligan ring is being inserted in this case, after which the patient can be shifted under the femtosecond dock. You can see here that the Maligan ring has allowed an adequate pupillary dilatation, and we are able to plan a 5.5 millimeter capsulotomy and an adequate nucleotomy with that. So I'd just like to conclude that the technology of flax has evolved to find widespread use not only in conventional cases but in all forms of complex cases. And it's time to take the leap of faith and finally switch to the power of femto. Thank you.
Thank you very much, Dr. Gitansha. Any comments or observations or questions? So, she's very eloquently described and shown videos as to how complex cases are made simpler by doing the femtolaser assisted cataract surgery. Obviously, not all of you or all of us have the femtolaser, but I think with the prices of the LOIs coming down over time, I think the percentage of patients getting the procedure done through femto would increase. Let's go on to Dr. Ramamurthy now.
So I had a question.
Yeah, sure.
I had a question.
Yeah.
So when we talk about the posterior polar cataracts and
Yes.
we talk about non-flex cases where we are doing hydrodelineation versus in flex where we are doing femtodelineation. So in femto, because we are not going to, do hydro in those particular cases after we have done femto.
Yeah.
So how do we ensure that the air or the gas buildup is released and it does not affect the already thin posterior capsule?
So the first thing, the question is that it's not, it's basically a pneumodelineation that happens, and that's automatic, that a pneumodelineation, because there is going to be the areas of unison where the gas would go, right? So what you have done is that you have seen that whether there is a posterior defect or not, and you have raised the level from say a 500 microns as the offset to maybe 800 or 1000. Once the offset is raised, the pneumodelineation is going to come at a level which is much higher than the posterior capsular defect, if at all it is there. Do you understand? It's not going to go below that. It will go above the epinuclear cushion. So there is no rupture that happens of the capsule. This is absolutely clear. This was, if the offsets were lower, this Lawless had reported that pneumodissection causes a rupture, but that was when they went back and saw the default settings were not 500 microns. So if your default settings are very low, then only you can have, otherwise the cleavage goes along the area where the epinucleus and the nucleus meets. So there is no need for any hydro procedure at all. The pneumodissection in itself is sufficient, and the pneumodissection never ever breaches the epinucleus because the epinucleus is strong enough. See, when you are doing a femtolasic or you are doing a smile, it is at a micron level that you are working. Okay, so the point is that if you are cutting a flap, it's not that you are having the cavitation bubble go deep down. It's only at that limited plane that you have the bubble. So similarly in this, it will go between the junction of the nucleus and the epinucleus.
And so in this case with flex, you should, the kind of parameter or the thing that you are using strategy, it should be circular cuts versus, or you can use any
That
pattern.
doesn't matter. The point is circular cuts or whatever is just giving you concentric cuts so that you are going up to the outside. So Lensex gives those circular cuts. In our particular case, in say Catalase or whatever,
So
you can get a grid pattern, but you can get circular also. You can skin the cat in many ways. There is absolutely no issue on that. It is just a question that you are making it into segments, so that as you keep on taking away the central core nucleus, there is no manipulation. Then you take out the next core, and then you take out the next core in concentric rings. It's only at the last stage that you are going to disturb the epinucleus. So therefore you never have a nucleus drop, because the epinucleus is like an airbag that you have say in a car. So it's going to give you a protection.
It also depends on the grade of the nucleus. Like posterior polars usually, apart from the polar component, are actually very soft cataracts. So in soft cataracts, it's okay to just kind of divide it into either quadrants or sectants and not go on with the grids of those quadrants, because it's harder to get a hold also while breaking it. Also, another important thing to remember is the more grids we form or the finer grids we form, the femto passes more, so the pneumodelineation and the amount of bubbles that are releasing will also be more. And in normal cases, it's just simple. All you do is gently just push it down or nudge it a little bit, and you'll see those bubbles actually escape before you proceed with the rest of the case.